So I wanted to welcome everybody to today's student webinar. Really cool opportunity here where we have two poster presentations that were just delivered at the 2024 APTA CSM meeting in Boston. For those of you who have not yet been to CSM, I highly recommend it. It's a lot of fun and so much opportunity from a professional development standpoint. I know that some programs sponsor their students to go, and if you have that opportunity, I highly encourage you all to go. So much to be gained from knowledge and upcoming research and networking and making connections and just all around professional growth and support. So highly recommend you all to go. But what's really cool about this too, and those of you who are familiar, thinking about spine and sports core values of educate to grow and excel in quality and empower innovation, those three in particular really hinge a lot on evidence-based care, right? Evidence-based care is how we really drive, really good patient outcomes, and a lot of that is driven through the research that we're performing or that physical therapists are performing out there. And so today we have two really great presentations. Our first one is on implementation of telehealth in physical therapy. And for those of you who are unfamiliar, I do want to introduce our first two guest speakers. First off, we have Starla Schwartz. Starla is one of our physical therapists. She has been at Spine and Sport PT for now officially, I think just over 5 years, right, Starla?
Almost 6 actually, but yeah, 5.
Okay, perfect. Well, 6 years. And she currently serves as our Director of Clinical Services. So she really leads a lot of our clinical support programs, leadership development programs, and clinical excellence programs here at Spine and Sport PT. In her career, she has been published. She has a couple of publications, one in particular through the Physical Therapy Journal of Policy Administration and Leadership. She also did She did present on a platform presentation for last year's APTA CSM meeting, and was also in the poster presentation that we just had here. With Starla, we have Rick Katz, who is a physical therapist as well, obtained his degree from CSUN and UCLA before getting his DPT at EIM Institute in 2013. He is also currently the president of the California Physical Therapy Association. Those of you who are attending PT school in California, you probably have seen Rick guest lecture at one of your classes before, but he does also serve as the Vice President of Business Development and Payer Relations here at Spine and Sport PT. So we are all very excited to have both of them on the call today. And with that, I will turn it over to Starla and Rick.
Thanks, Patrick. Okay, so let me share my screen here and we can talk to you a little bit about what we did at CSM this year. Okay, so like Patrick said, we presented on telehealth, and we talked about kind of the long-term implementation of telehealth. So really wasn't very big in the profession prior to COVID. And so in 2020, we started to really emphasize our telehealth program and see a lot more visit volume. So I'll talk to you a little bit about that. So here's a picture of us at CSM. So Rick was the primary author on this presentation, and we had several other spine and sporters who had contributed to this as well. So Melissa Walls, who is one of our therapists in Orange County, Dr. Joe Verna, who is one of the original founders of our company, and John Mayer, who is the lead researcher as part of the U.S. Spine and Sport Foundation, which I don't know if you guys have heard about that at all, but we partner really closely with them. So Spine and Sport PT and U.S. Spine and Sport Foundation, separate companies, but partner with each other through Joe Verna. So he's part of both organizations. And I really just want to highlight that this is a huge opportunity for us, as spine and sport employees, and then for all of you guys who are, going to be looking for somewhere to work. If this is something you're interested in, there are an incredible amount of opportunities to get involved in research through the U.S. Spine and Sport Foundation. So just kind of food for thought, if that's where you see your career going, I encourage you guys to come talk to me about it. Talk to Patrick, Rick, anyone. And I just wanted to highlight some of our other therapists who have been published, and these were therapists who contributed to the supporting articles as part of this presentation. So Brandon Phelps, who's in Imperial Valley, Sam Fost, DJ Mortimer, Monica, who is in San Marcos, Alex, who some of you may know. So a lot of other therapists who work at Spine and Sport who have also been published. All right, so let's talk about implementing telehealth. So like I said, we started this during the height of COVID-19. So I personally worked in one of the clinics that were inside of an LA Fitness. So someone said they were from Encinitas. I don't remember who it was, but that used to be located inside of an LA Fitness. So there was like 3 times, I think, where the gyms got shut down and we were kicked out of our clinics. So luckily, I wasn't out of a job. I just had to switch pretty rapidly over to telehealth instead of in-clinic treating. So at the height of COVID, we were doing about 900 visits a month. So it was a substantial part of our business. Right now, we only do about 200 visits a month. It's less than 1% of our business. But something that we still do on a regular basis, we do have some dedicated telehealth therapists who work for the company. And so the primary ways that we use it now are to support our rural and underserved areas. So we have some clinics in the desert, which are traditionally pretty hard to staff. And so the way that we can continue to maintain a high level of access for our patients is actually through telehealth. So we'll have some PTs doing telehealth evals, reevaluations, and following those patients throughout their plan of care. And there's a PTA and there's, some other PTs on site, but this is a way to just, staff up and allow us to get more patients into the clinic to get treatment from the PTAs and support staff. Some other ways that we've used it is to prevent a gap in care in the event of inclement weather. As you guys are aware, nobody likes to drive in the rain in California, so it's a good way to, continue with their treatment in the event of rain. Or if someone is traveling, if they have transportation issues, that's a big one too. If they just can't get into the clinic, this is a great alternative as well. So thing that we've started to do, which I thought was really wacky when we first started doing it, but we can perform telehealth sessions in the clinic. So patient physically comes into the clinic, but we'll do a telehealth session there with a provider who's in another remote location. And the reason that we may do that sometimes is if, a patient needs to be reevaluated and there's not a PT on site, the PT can actually jump on and do a telehealth reevaluation. And then the PTA is right there kind of learning, seeing, what's happening with the patient. The PT can direct any changes to the plan of care, and then the PTA can implement it right there on the spot under the direction of the PT. So some creative uses for it. I'm curious of those who are on camera, raise of hands. Has anyone used telehealth? Seen your CIs do it? Got any exposure? Gabby has? Okay. Oh, and then Alexandra too. Okay, cool. If anyone is curious, please let me know. We can always get you a little bit of exposure to this if it's something that you're interested in and your CI hasn't been doing any. All right, so let's switch gears a little bit and talk about some of the regulatory issues.
Yeah, so we talk about wanting to do telehealth. We kind of ran into this issue right away with it as to, well, is it legal to do it? Is it can we get paid for it? And what are some of the regulatory restrictions? And there's a few things that kind of happen simultaneously. And although the pandemic was a horrible imposition to all of our lives, out of the pandemic came some changes that we hope will endure beyond the time of the pandemic. And one of them had to do with the fact that when we entered the pandemic, physical therapists and occupational therapists are not listed under CMS, Medicare, as authorized providers of telehealth. That's really hard to believe that we were not even listed as somebody who can do it. And with the pandemic, we got temporary lifting of that restriction and a waiver that is in place through the end of this year. And that's it. After that, our ability to do telehealth for the Medicare population goes away. So through the efforts of the APTA right now, there's a bill specifically related to expanding the telehealth and adding physical therapists and occupational therapists as permanent providers under Medicare. And why that's also important is because oftentimes when Medicare sets a rule, you'll find that private payers will adopt that rule just as basically Medicare setting the precedent. There is no mandate for any insurance company to pay for telehealth, but if Medicare pays for it, they're more likely to do so. In addition to that, in California, something that we worked on prior to the pandemic and had a little bit of foresight is that we were able to get passed. We end up saying it's mostly the medical community. It wasn't just physical therapy. An act that created payment parity between settings, meaning that physical therapy provided in a telehealth situation will be paid at the same amount that it would have been paid for in person. And that is huge because a lot of states don't have that, which allowed insurance companies either to pay less for the telehealth session or not to pay at all. But in California, we have that parity law in place, and it really helped us get through the pandemic. And that will survive whether or not Medicare allows it or doesn't allow it. It just means if an insurance company has it in their benefit plan, that they will pay the same as they would if the patient was in front of you for a session. So that was great. There's also another area that is impacted us and impacts the use of telehealth too, and that is the supervision requirement for physical therapist assistants. And if you don't know it already, but physical therapist assistants are under Medicare. We're not allowed to bill for their services unless a physical therapist was on site and providing direct supervision. So if a physical therapist wasn't there, the PTA is there alone. They couldn't provide telehealth services to a Medicare patient, and they could not provide any direct services. Now, legally in California, they could treat that patient without the physical therapist there, but Medicare would not pay for it. So during the pandemic, they have also changed that supervision requirement to general supervision. And what's kind of interesting about that is general supervision is what occurs right now for home health. Physical therapist assistants can go see a patient in a home health setting, in a skilled nurse setting, in the hospital setting without a physical therapist in direct supervision on premises with them. But in private practice, it hasn't been allowed. But that has been also, there's been a waiver through the end of this year, the pandemic. So now there's another act trying to make that permanent. So the pandemic in some ways kind of was a proving ground to say, hey, you lifted all these restrictions during the pandemic, and guess what? Nobody died because of it. The care was still delivered on the same level it would have been if the physical therapist was on site. And so we are trying to get both of these acts passed. There's a good chance that one or both of these acts may be added on to the next budget omnibus bill that's coming through. You've heard about this happening twice already, where the government was going to shut down unless they passed this budget act. And in March, we come up with another deadline. And sometimes when that large bill goes through for the budget, they dump a number of other smaller bills on board with that to be passed at the same time. So we're hoping all that occurs, and keep your fingers crossed. It doesn't mean that telehealth will go away, but if it's not passed, it's a challenge to be able to treat patients covered by Medicare. We can move on. I can answer questions about that later. Is this me, Starla? Or is it? Yeah. Okay. So the future of telehealth. So telehealth has really become an adjunct in many practices. As Starla mentioned, we were up to about 7% of our population during the pandemic, and that really mirrors what's happened in the industry as a whole. The private practice section of the APTA reported that telehealth was up to close to 11% of the total practice during the pandemic, and some practices even greater. And then as the pandemic lifted, a lot of practices either let it go, or they've done kind of what we've done and used it when a patient just can't come in, or in rural areas. I actually spoke with a therapist that I knew up in Alaska during CSM, and they said that telehealth has become a primary mode of delivering care in their rural areas. And there's therapists I spoke with said, yeah, she handles communities that have maybe 15 people living there. And there's no way they're going to get to a therapist. And so telehealth has been a savior for them. So, and we also saw at CSM a lot of vendors that were showing or providing services that augment the telehealth experience in terms of measurement capabilities and evaluating the patient that when you don't have your hands on them in terms of strength and range of motion and function. So we've become very innovative because of what happened through telehealth, and that's something that's going to be sustainable in the future. It doesn't substitute for hands-on care, but it's a great adjunct, and it can allow your patients to increase their function without being in the clinic. Next slide.
So that's everything for us. Patrick, you wanted to save any questions to the end, right? Okay.
Yeah. Yep.
Awesome. Thanks, guys.
Perfect. Thank you so much, Starla and Rick, for your presentation. Again, everybody, if you do have questions, please feel free to drop those in the chat, or you can use the raise hand button, and then we'll get to you once we get to the end of the next presentation. But I wanted to make sure we had enough time for our second presentation, a really cool inspirational case study on, intensive physical therapy post brain injury here. And we're very excited to have Gabrielle Stanley, who is among your peers here. Gabrielle is a third-year physical therapy student out of Duke University. She is with us at our Sorrento Valley Clinic underneath her CI, Eric Schleicher, who's one of our regional directors. So also shout out to Eric Schleicher for supporting your student and allowing her to join us on this call today and leading us in this discussion. But I didn't want to give too much details away, Gabrielle, so I'll just turn it over to you when you're ready.
Alrighty, hello everyone. I'll go ahead and share my screen here. And are we able to see that? Patrick,
Yes.
Are you seeing my screen? Okay, beautiful, Yep. Perfect. Let me get in my presenter mode. So don't have quite as many letters after my name as Starla and Rick, but I'm getting there. Alrighty, bear with me here. I'm hoping it'll let me. There we go. Okay, so I presented on at CSM. I presented a case study on someone who had a brain abscess injury, but when presenting to kind of a group of outpatient ortho SPTs and PTs, I thought it'd be more applicable to give you the takeaways on how we can apply it in clinic. So this is my patient. I got his sign off to include all of his information. He's kind of become a friend of mine. His name is Aaron. He acquired his brain abscess through the most common way to acquire a brain abscess, which is via some sort of infection. It's common to get it through kind of a rare case of strep. And his case of strep was obtained swimming in Lake Michigan, and actually not the first case of strep that led to a brain abscess from swimming in Lake Michigan. So I will caution everybody there. But I met him through Duke's Neuro Camp. It's a nonprofit 1 week long camp where we kind of seek out members of the community with a financial need, high motivation, and ideally acute to subacute categories, because we know that that's where the most amount of change is able to be made. And I opted to do this case study on him because he's kind of a unique case. What I came to find out is that there's no CPGs really for brain abscess. And so we were kind of flying blind with his treatment. And so I wanted to see if we apply the principles of the stroke CPG, namely propulsion, hit training, and gait training, is that applicable? And that was kind of goal number one. And goal number two was to see if you can create meaningful change in a short period of time in someone who's in that subacute chronic category. Because the argument right now is that most of the neuroplasticity takes place in that acute subacute category. So for someone who's 18 months out, we were wondering, can you kind of put a dent in their ability to walk a little bit quicker and improve their balance? So that's Aaron. Here's a little plug to Durham Neuro Camp if anybody's interested in that. Really cool program. And I promised I would promote him as well. He's a really cool guy. He kind of took this injury and and ran with it. There's a really neat article that I linked called Making Chef Lemonade, if anybody's interested in hearing a little bit more about his story. But he was a chef prior to being injured. He is hemiplegic now, so he doesn't have a lot of use of his right side. And so he's taken that, and I encourage everybody to kind of check out his Instagram. And he basically does a lot of like adaptive cooking now, and he's made a career out of presenting to stroke populations, amputee populations, working with the VA, and partnered with somebody who creates these adaptive cutting boards for people who only have use of one upper extremity. So really neat stuff. I encourage everybody to look into that. So Aaron came to us. He was ambulating independently, but anytime he was with us, it was like very aggressive contact guard, not the most stable gait, kind of the typical neurological gait pattern. His goals were to walk on the beach without his AFO, and he used his AFO at all times. He wanted to improve his gait speed, feel confident getting off the floor in case of a fall. And he wanted to jump, which is kind of fun because we weren't working with insurance, so we could kind of do whatever he wanted to do. Some of these goals seemed lofty, namely jumping. We had some clinicians and professors that were like, okay, let's make our expectations realistic, but it was a goal of his, and he's kind of a shoot for the moon type of guy, so we went for it. So if we could just review his staging and kind of the staging that people typically encounter and when. We just went off the staging of stroke because I couldn't find in the literature any staging of brain abscess. So we know that acute period is like the 72 hours to 2 months, and subacute is 2 to 6 months. That's not so much the spine and sport realm, but that is arguably where people say the best rehab potential takes place, because your brain is still in that like neuroplastic stage immediately post-injury. We come into play more in this subacute to chronic region. And so his case is really well fitting into the outpatient ortho sort of world, because he was 18 months out. And so we're wondering, can you make a dent in somebody's ability to improve when they're that far out? So the first principle we're going to talk about is propulsion. We hit this really hard with Aaron because a lot of his goals were functional, that ability to walk faster, ability to kind of have a little bit better balance when getting off the floor. And with propulsion, there's a really neat study that I encourage everybody to look at called These Legs Were Made for Propulsion. And basically what we know about people with neurological injury, this study was done on stroke, but it applies to a lot of neurologically injured populations. What we know is that there's a huge inefficiency in gait. And you could get up to 60 to 80% someone's heart rate max just by having them walk for a little bit, especially in the early periods. And so what this study did is they broke down, okay, where is that coming from and what can we target to get these people walking faster? So what we know in regards to propulsion is that most of that propulsion takes place in that terminal stance position when you've got the max amount of dorsiflexion that's going to recoil and kind of propel you forward in space. And to add insult to injury for this population, they've usually got some sort of calf deficit, if not like fixed plantar flexure contractures. And to make matters worse, you're getting even less recoil because they're forced a lot of the time to be into AFOs for the sake of stability. So the question is, how do we overcome that? And the control group, kind of the comparison they use is just people attempting to do calf raises or some sort of plantar flexion with a band. And you don't get a whole lot of functional change in that. And so what this study found out is that most of your propulsion power comes from two different things. It comes from that plantar flexor recoil moment that you get with 10 degrees of dorsiflexion, ideally. But more than that, it comes from the trailing limb angle that we see kind of on this right side. So then the question is, great, how do we access more of that in our practice? And functionally, the best way to do it is, again, as opposed to just like isolating the plantar flexors, or in the case of getting a trailing limb angle, as opposed to just strengthening the glutes and stretching out the hips, you want to get them to walk. And that's where the most change is going to stick. So you could either, in terms of increasing the dorsiflexion moment in terminal stance, you could apply some sort of posterior perturbation to the ankle or directly to the hips if you're trying to increase the trailing limb angle. So kind of different ways that you could see this implemented. For Aaron, what we did was we had him We took off his AFO. We had him do it first with the AFO and then without it. And we had him walking uphill eventually with a posterior perturbation as fast as he could, with a big emphasis on the cues of when to push. So just kind of the repetitive as he was walking and I saw him in terminal stance, he said, push, push, push. And the verbal cues do make a big difference in that, I found kind of anecdotally. We've got Kendall here representing from our clinic. She's our front desk gal. But another good exercise is just the posterior perturbation band pull. I know a lot of people don't have access to aids 24/7. So a lot of times these neurologically injured patients come in with a caregiver or a spouse. So I like to incorporate them in the care by having them pull the band backwards. And then if Kendall were my patient, I'd obviously have a gait belt on her, and that way you could kind of be guarding. Another good way to do it is like this sled push sort of tactic, where you're pushing against them and your patient is walking forward. That's another good one to do with people who don't have the greatest balance. You could do it in like the parallel bars. You're typically not getting that much of a lean from patient who's neurologically injured too. So the good news is that you're in front of them. So if there is a loss of balance, you're there. Or, I mean, we're busy. These clinics, we see a lot of patients. So if you don't have a lot of time and you know that a patient is safe to walk, put them on the treadmill and give them a 1 or 2 pound ankle weight. You could still get benefits from that. And what's cool is what the study found is that those benefits in EMG activity measured on the calf stuck for up to 2 days. So one session of therapy in an hour can last that long if you're targeting it properly. So that's our first principle, is propulsion. And that's kind of how you would implement that. Second principle is high intensity training. We know that the neuroplastic benefits that you get from that brain-derived neurotrophic factor kind of kick in at that 60 to 80% range. And we also know that as practitioners, the patient you want to get sweating and working super hard isn't always the neurologically injured patient. Because for lack of a better way of putting it, it can be scary. But these patients tolerate it really well. And it's also not that hard to get their heart rate up. A lot of times you could get it from just walking, if not walking with some sort of posterior perturbation. So what the research shows and what the research backs up is that improving or increasing your heart rate max and maintaining that as long as you can, that percentage of your heart rate max, leads to improvements in gait post-stroke and actually improvements in balance as well. What's neat with the Parkinson's population is that it can kind of serve as a buffer for those Parkinson's symptoms. So you could get someone whose Parkinson's is very well progressed. And I've been recently working with a patient who came in, and I've only been with him for a month. But you focus on getting their heart rate up into that 60 to 80% range, and you will see a difference in their symptoms. So are you going to change the disease? I mean, debate's kind of still out on that one. Likely not. We're likely not decreasing or increasing the amount of dopamine in someone's brain, but you can increase their quality of life by getting them to walk and move a lot better. And that's kind of what matters in the end. So when we're talking high intensity training, I'll go back and we're talking prescription. You want to get 60 to 80% that heart rate max. So I encourage everybody in your neurologically injured populations, your MS patients, your Parkinson's, your stroke, what have you, calculate their heart rate max, do that 208 minus 0.7 times their age and 60 to 80%. And half of these older adults, because those are most of the people we're getting with neurological injury, half of them already have access to like an Apple Watch and just don't know how they should be using it. So the patients that I work with, I calculate the heart rate range I want them at minimally, and I show them how to get to that on their watch and monitor themselves while they're exercising. And I encourage kind of the safest way to do this while you're at home is, or not in the clinic at least, is get on a bike, get on a UBE, get on upper extremity or lower extremity, and just check your watch and work up to that number. And then with patients who are on beta blockers, I know it can be kind of, you might want to hesitate to put them on, but they can tolerate it just fine too. The NIH recommends 164 minus 0.7 times age when calculating that. But the point is, when you give somebody a number and you show them how to access this, they're going to exercise a lot more in their own time, at least is what I have found in my own personal experience. So different ways we can implement this. If everybody could take a second to appreciate my GIF as well. That took me a long time to put in here. So we got my gal doing sit to stands over here. But the ways we implement this, ideally, you want high intensity training sustained. You want them working up to their max, holding that 60 to 80% as long as they can, and then coming down. That's when you're going to get the most benefits of that BDNF hormone being released in the brain. But for a lot of patient populations, maintaining that high of an intensity for a long time isn't the best idea. So with your MS patients, for example, who should be limiting their exertional activity throughout the day to make sure they have enough gas in the tank, so to speak, to make it to the end of the day, those are the patients where interval training is going to be a little bit more appropriate. So you slowly work them up to that level, stay there for a minute or two, and come down from it. But you'll still get benefits from it. Different ways to implement this in practice. All of Aaron's interventions that we did, we ensured to slap a heart rate monitor on him, and whatever he was doing, we did it up until that 60 to 80% mark and made sure that he stayed there for at least a minute or two. One of his goals was jumping. So to make that a functional intervention, we get patients all the time who have things that they have personal goals that might not match up with insurance pretty well. But what we can back up with evidence is that anything your patient is doing in the 60 to 80% heart rate realm is going to help them. So whatever their goals are, you make it actionable by getting them up to that level. So he did maybe 10 to 12 jumps, which was enough to help him maintain that 60 to 80% level. To work him up to the jumps, we had him doing like power sit to stands with an emphasis on, we'd give him posterior perturbation at the hips to kind of mimic a jump. But that was his personal goal, and that's how we made it relevant. In the Parkinson's population, Nordic walking is really encouraged because you get that large swinging gait pattern. And that is really good carryover into regular life, because we know through, for example, LSVT big training, you want to emphasize big steps, big arm swinging, because when they step away from physical therapy, they're more likely to return to kind of a normal level just by thinking bigger. This patient, one of her goals was to, so she has Alzheimer's, and so we wanted to really get the benefits of BDNF. And her husband said that while she was kind of dual tasking, when he was grocery shopping with her, anytime she was doing a physical activity, she was a lot more likely to forget what she was doing and kind of walk off. And so how we made this relevant is in clinic, we loaded up a rollator and we had her push it around the clinic, and you get a little bit of benefits from propulsion on top of that 60 to 80% cardio. Again, one of Aaron's goals was to feel more confident getting up off the floor. So first we had him do it on a stable surface, getting that heart rate up from 60 to 80. And then we had him do it on an unstable surface. And something that I want to highlight here is that the benefit of doing something perfectly 10 times in the neurological population is not as good as the benefit of doing it as many times as you can, maybe in a kind of sloppy fashion, but getting your heart rate up while you do it. Because what we know is that the changes you're making stick a lot better when you pair it with high intensity cardio. So other ways to do it, I mean, if you're in a pinch, if you don't have time to supervise your patient and stand really close to them, pop them on the bike and tell them the number that you need them to get to. Or something functional like sit to stands can even become a task that changes neuroplasticity in the brain. The final principle we're going to talk about is gait training, specifically salient gait training that relates to your patients. And so what we know with gait training is that doing the actual activity that they struggle with is the best thing for them, or mimicking it as close as possible. So we kind of want to stray away from more the pre-gait tasks of step forward, step backward, step forward, step backward in the parallel bars, or step out to the side, step back in, step out to side, step back in. The stuff that's not actually walking doesn't make a huge difference in the neurological population. If you want to get changes in walking, you need to do it while they're walking. And what we found in this study that I listed right here is that you don't just get changes in gait speed and gait function, but you actually get better balance too, which is really important. That was one of Aaron's goals. And it's kind of interesting to me the way gait training can affect, for instance, your score on a Romberg or a mini best test, but it really does make a big difference in balance, more than you would think, or at least than I thought intuitively. And again, this isn't just for the neurological population. This is true with any patient you're working with. Our elderly population, our MS population, our Parkinson's population that we know are high fall risk, get them gait training and get them gait training with the relevant tasks, because that's what sticks a little bit better. So examples of this, one of Aaron's goals was to be able to walk at the beach, and in Durham, North Carolina, you're not anywhere near a beach. So we brought him out to some wood chips outside. When we're talking feasibility, I know we don't necessarily always have the luxury of a full hour one-on-one with our patients where we can guard them and watch them. But if you only have 10 or 15 meaningful minutes, you could work with a patient, get them walking outside with a gait belt, put a heart rate monitor on them, have them walk fast, and just get as much bang for your buck as you can. This patient was a patient that I was working with. This is that same Alzheimer's patient. And she struggled with spatial awareness. Namely, she had this big dog that would kind of walk up in front of her and sit down. There was a big fear of tripping that her family had. And so what we did was we mimicked unstable surfaces by, and I do this with a lot of my balance patients, you put a couple ankle weights or gait belt or whatever you can find down underneath a black mat, and have them practice navigating that and kind of instruct them through the balance of make sure you have a wider base of support when you're on something less steady. Like this is meant to mimic maybe mud or wet grass or somewhere where your patients are going to be walking that's not quite as stable, and then give them that obstacle to step over that they're going to encounter in the real world. And don't just have them practice repetitive stepping, but stepping with walking. That's what's going to make the difference. And in terms of exercise prescription, I mean, a lot of patients don't have access to like Eric's or foam pads at home. So pop them on a pillow, have them practice standing on a pillow or walking over a pillow with a hand on some sort of supportive surface. So in terms of Aaron's goals, we did get him walking on the beach. We could just recap the relevant training for that was gait training on wood chips. We got him walking faster, which we did through propulsion and high intensity training, that 60 to 80%. We got him feeling confident in getting up off the floor. I think I showed a picture earlier where we had him doing it on a Bosu ball. And again, the way we did that was doing the task that he needed done at 60 to 80%. And he was able to jump with a little bit of help from that power training that we gave him. So this is the picture that Aaron sent me the day that he walked on the beach without his AFO. And I think it's a good reminder that what we do is really important and it makes a difference in people's lives. So don't let yourself get lazy with the interventions. Research what you can do and get the most bang for buck out of your time. If I could just add one last shameless plug, this was my research that I did with Aaron. We did find a lot of other interesting things in the upper extremity and whatnot. So if anybody wants to chat neuro or even how to get a case study to CSM as a student, it's shockingly not that hard. It seems like there's a really high barrier of entry, but I mean, if you have a patient that you're interested in, the outside work took me maybe 2 to 3 hours. So if anybody's interested on how they could do that and they have a case study that they're interested in or want to talk neuro, feel free to reach out. But yeah, that's all I got.
Awesome. Thank you so much for sharing that experience and a lot of really great applicable knowledge that, you know, I think everyone can take and apply immediately to their clinical practice. Thank you so much, Gabby, for that, and know that we're all very proud of you. Give me 1 second. I'm going to stop the recording here. 1 second.